Good morning. I'm Liz Goldstein, Executive Director of the Anticoagulation Forum, and like to welcome you to today's webinar. I know how many Zoom meetings you have, and I appreciate you making time for this AC Forum program. Today, we'll be showcasing an exciting new resource from the AC Forum that I hope you'll find very useful, the DOAC Playbook. Our goal was to provide one go-to place for the key information you need to manage a patient on a DOAC, whether you already manage DOAC patients or still have a majority of warfarin patients and want to transition to DOACs. I am thrilled to have four of the authors of this playbook on the webinar today. Dr. Arthur Allen has practiced as a clinical pharmacy specialist for the Veterans Health Administration since 2001, serving as anticoagulation program manager at the VA Salt Lake City Health System since 2014. Dr. Jack Ansell is the founder and past president of the Anticoagulation Forum. He is a national leader in the promotion of high-quality anticoagulation management, authoring over 260 peer-reviewed manuscripts and over 60 textbook chapters and texts on anticoagulation, and that number is probably even higher now. Diane Wirth is an adult nurse practitioner at Grady Memorial Hospital in Atlanta, where she serves as the manager of the heart failure program and remote patient monitoring program. And Dr. Sara Vazquez is a clinical pharmacist specializing in thrombosis management at the University of Utah Health Thrombosis Service in Salt Lake City. Dr. Vazquez's clinical interests include direct oral anticoagulants, drug interactions, and post-thrombotic syndrome. And I'm very proud that all four speakers are current or past AC Forum board members. Here are their disclosures. This webinar is accredited for physicians, nurses, and pharmacists. Please visit AC Forum's website, and we'll also add the link into the chat to claim your credit. We received tons of questions in advance, and the speakers have incorporated many of the answers into their cases that they'll be presenting today. Please feel free to ask questions during the presentation, though, also during using the Q&A box. The chat has been disabled. Thank you again to our authors and to everyone joining us today. I'd like to now introduce Diane Wirth.
Thanks, Liz, and welcome everyone. Very excited. This is a long-awaited work that we spent many hours on and worked with our partners at Myland, as well as sponsored through some funds that we got from pharmaceutical companies, predominantly Janssen. And it is a phenomenal guide that you'll use every day if you manage anticoagulation. So this is just what the front of the book looks like, and this is the table of contents. And so this is a little bit different format that we usually do. So we're going to briefly go through all of the items on the management of DOACs and take some case studies, and then hopefully have some time for questions at the end. Next slide. So what exactly is the DOAC playbook? Well, I kind of equate it to one of my favorite cookbooks in the kitchen, where it guides us how to manage our patients that are taking direct oral anticoagulants, where you may have to change your recipe a little bit based on what ingredients that patient comes with, but it's going to incorporate both evidence-based studies that we have looked at, as well as what our expert clinical consensus was for managing different clinical situations. And this is going to come from a variety of clinicians that contributed to the playbook. We're just four. There were many clinicians and board members, as well as members of our centers of excellence that contributed to this. The goal was designed to the end product being a concise, practical guide for people that are boots on the ground. How are you going to take care of your patients and utilize this in daily practice? So like I said, it's kind of like a cookbook. You're going to get some good ingredients for you to take back and use in your clinical practice. So going through the book, the first information section is on DOAC information. It has 4 really awesome tables in there that I think you should be able to print. They're in color and put up on your boards. But the first table shows what the mechanism of action is for each of the drugs, what their indications are that they're FDA approved for, what the half-life is, and that's really important so that you don't have to go looking if you have someone that's having a critical bleed, you know, when you could expect the drug to be wearing off, how the drugs are cleared, and any special instructions for each drug, such as like dabigatran about storing it in its original container or taking it with food if it's rivaroxaban. The second table gives you the contraindications for each of the drugs, as well if there's any dosing adjustments based on their renal or hepatic impairments, and body weight guidance as well. Then the third table is on the PK/PD data, and the fourth table is really nice and will be great for you to use when you're teaching new people that are going to be using these drugs on the different dosages that are available and what the indication is, so that you're using the correct dose for the correct indication and not underdosing or overdosing your patients, and then what special directions are for use. So the next section that we're going to go into is going to be on patient selection in the book, and that's going to review what the bleeding risk factors are for each patient and what patients you would want to avoid direct oral anticoagulants in, as well if there's any contraindications for the use in this population. So Arthur's going to take this first case study, so I'm going to turn it over to Arthur now.
All right, thanks, Diane. So we're going to go through a case here and show how the playbook can assist. So in this case, we have a 70-year-old morbidly obese female with a recent diagnosis of atrial fibrillation. Past medical history is significant for a little bit of mild aortic stenosis, recognized on echo, hypertension, diabetes, osteoarthritis of the knees, and there was a fall in the past 6 months without injury. Medications, lisinopril, metformin, and some naproxen for that OA, as well as a multivitamin. Significant labs, patient has a hemoglobin of 10.4 at baseline and has age-appropriate renal function. Next slide. And so, you know, this table, these tables allow us to look at both bleeding concerns as well as some contraindications and controversies. And I think it's important to really recognize that we tend to want to draw lines in the sand, if you will, about how, you know, you can't use a DOAC there, you can't use a DOAC here, when in fact, many of the issues we're concerned about are controversies. And so if you look at the table on the right, you'll find that we actually split the table up into patients who really should avoid DOACs, and there's a good reason for that. In some cases, it's because they actually have had, we've had studies that show harm or that show inefficacy in those trials, or we have some situations like pregnancy and those kind of things where we know we shouldn't. But in other cases, there are these controversies, and this has been kind of a moving target. So if we use these tables and we apply it to this case, what we find is we have a patient who's elderly, which plays into a bleed risk. We have the use of anti-inflammatory medications, which can definitely drive bleeding risk. We have a history of a fall, probably not terribly concerning, but one fall in the last 6 months. We have a baseline anemia. And so when you think about bleeding risk, you wouldn't want to use these tables and say, gee, should I anticoagulate or shouldn't? And let's put these on a scale and see which is worse. Rather, you want to identify bleeding risk that can be modified. And so in a case like this, you say, well, we shouldn't be using anti-inflammatory medications in a patient anticoagulated, so we see what else we can do for pain control. If there's concerns about falling, you see what can we do about modifying that risk? Do we have an appropriate level of care? Do we need a cane or some other kind of support structure and those kinds of things? So we try to control that which we can. With regard to the other components of this case, there are some controversies here. We have the issue of morbid obesity, and this was really brought into light in 2016 with the ISTH recommendation against the use of DOACs in this setting. And I think because of that, many people drew a line in the sand. Honestly, since that time, there have been a lot of observational data that have come out and really kind of moved the needle on this. And we shouldn't see the issue of obesity as a contraindication, rather, again, as a controversy, and really a controversy that I think has been pretty well put to bed. When you're going to make a decision that, gee, I shouldn't use a DOAC, what you're actually having to say is, well, if I don't use a DOAC, what am I going to use? And are there better data there? And so you have to be careful about drawing lines. You know, and we also have, in this case, I've already mentioned the anti-inflammatory we would want to stop. And then we have, you know, this kind of anemia. It might be wise to try to work that up, see if there's any kind of workup that we can do to mitigate any kind of risk of bleeding, specifically GI. And then with regard to the valve, there's this issue, there's these, you know, controversies around the issue of valve and what is valvular AFib. So if you see in the table on the right, we have mechanical heart valves listed as a contraindication, and then valvular AFib. And I think this has driven a lot of confusion. Again, I hope it's been put to bed a bit by now, but valvular AFib has been kind of, the definition was all over the place initially, and really that's been distilled down to the presence of a mechanical heart valve or moderate to severe mitral stenosis, kind of period. And so there is no concern with the valve here. The obesity issue really has been put to bed. It would not prevent me from using a DOAC in this patient. And then the bleeding risk, I would do what I could to modify those bleeding risks as much as possible. And I'll turn it back over.
Thanks, Arthur. So the next section of the playbook deals with reasons why you would want to switch anticoagulants and how to do that. So there's a nice chart in there on how to switch them between, Liz, you can go to the next slide, that shows you when to start and stop the anticoagulant. There was a question that had come in earlier about switching a patient whose creatinine had gone up to unfractionated heparin. So you would go ahead and stop that drug. And then if you needed to switch them because of their, I'm assuming this patient was going inpatient, but if it was someone that was on one of the DOACs that is renally cleared, you would you could use the unfractionated heparin when the next dose would have been due. But there's a nice table here. We don't have a case study for this. This is pretty straightforward. And like I said, these charts are great. You can print them and blow them up so that you can put them on your boards in your offices so that you don't have to, it takes the think out of it. You've got it right there in black and white. So we're going to move on now, and Jack is going to do the next section on peri-procedural guidance.
Thanks very much, Diane. And so for the next couple of minutes, we'll talk about peri-procedural guidance as it applies to the DOACs. And, you know, everybody on this call, myself included, all of us, this has been the bane of our existence in the past, particularly with warfarin, in terms of the difficulty and around managing warfarin and bridging or no bridging and all of the changes and recommendations. I'll say in general, it is much simpler with the DOACs, but still decisions have to be made regarding peri-procedural guidance. And this table from the DOAC playbook basically outlines in a very simple way the 3 steps, and these are sort of global steps that one has to take. And that is obviously to assess the risk, the bleeding risk of the procedure. Number 1, number 2, if the patient is taking dabigatran, not as quite as important with the 10A inhibitors, but with dabigatran, you really have to know the patient's renal function, since that is almost totally eliminated via the kidney. And then step 3 is to design a pre and post procedural plan based on the bleeding risk of the procedure. So if we go to the next slide, which just highlights a simple case, this is a 55-year-old male recently diagnosed with colon cancer who presents to your service for guidance on when to stop Xarelto or rivaroxaban before colon resection. So looking at this case, this patient has got, number 1, elective surgery. You have time to decide what to do. Number 2, he's got colon cancer. And he's going for colon resection, which is major surgery and is a high-risk bleeding procedure. But he also has colon cancer. And so you have to worry a little bit about the risk of venous thromboembolism. That's the other side. He's at increased risk for venous thromboembolism. So if you go to the next slide, now this is hard to read all this, and I'm not going to go into detail, but in the playbook, it's very nicely outlined the various procedures and their bleeding risks. Now, this is not a exhaustive list of every procedure in the world, obviously, but it's a lot of the common procedures. And there's no way that anybody remembers this list. You just have to have it nearby so you can look at it. Some things you will remember, but you can see there are things that are minimal bleeding risk and certain dental procedures or cataract replacement, superficial biopsies and so forth. And then there are what we call standard risk procedures. And these, I would equate these to medium or moderate risk procedures. And you can see the list there. Again, I don't want to go through that. And then at the bottom in the red and over on the right side are a list of procedures that are high risk bleeding procedures. So if you look at this list, you can see our patient, if you look at the second bullet under high risk bleeding procedures on the left, abdominal and gastrointestinal surgeries, bowel resection, that's a high risk bleeding procedure. And so he is in that category. And then you have to make a plan as to what you're going to do. The next slide. And so here from the DOAC playbook is a very simplified table. And this data comes predominantly from a trial, the PAUSE trial, which I highlighted on the right in terms of the results and outcomes. I'll mention that in a second, but let's just go through this table. If we look at the DOAC type on the left, let's skip over the bigotran with a lower creatinine clearance and just go down to the next row, the bigotran with what is essentially normal renal function, rivaroxaban, apixaban, and edoxaban. So all of the DOACs in this case. If it's a low bleeding risk procedure, then all you need to do is, well, let me put it this way. If it's a very low bleeding risk procedure, you may not have to discontinue anything, but it's certainly very simple to discontinue 1 day before the procedure, as indicated in that X on in the box, and you stop it the day before the procedure. Next day you do your procedure. If it's a high bleeding risk procedure, you basically eliminate 2 days. And this was a trial design that was used in the PAUSE trial. On the right, you can see in this trial, the outcome of either 30-day overall bleeding or arterial thromboembolism. These were patients with AF who were receiving a DOAC, and they managed the DOAC in this fashion. And you can see that the rates, they weren't zero by any means, but the rates of major bleeding or overall bleeding were quite low. And in fact, these rates are essentially the same, if not a little bit better, actually, than what we see with warfarin, with bridging or without bridging therapy from earlier studies that were done. So it's basically equivalent to how the outcomes you see with warfarin therapy, and the incidence of arterial thromboembolism, the other side, when you take somebody off of an anticoagulant, is also extremely low. And again, it was equivalent to what you see with warfarin therapy when it's managed appropriately for perioperative situations. Now, with the bigotran, that in a patient with impaired renal function, less than 50 mils per minute of creatinine clearance, you can see what it recommends for low or high risk bleeding procedure. I mean, it's pretty straightforward. And then after you make that decision and the patient goes to surgery or has a procedure, and then you do have to have a post-procedure resumption plan. And so as you can see in the bottom, there's no DOAC taken on the day of surgery, obviously. And then if there's, again, excuse me, a high bleeding risk procedure, which is the case in our patient, you certainly would not start him the next day. And on day 2, the yellow indicates flexible dosing. And that depends. If I think in this situation, well, not only in this situation, in all situations, you probably want to touch base with the proceduralist or the surgeon just to say, how did things go, or were there any difficulties or what have you? But in this case, you'd want to know from the surgeon, how did the surgery go? Were there problems? Do you expect more bleeding? Was the, whether it's the reattachment after a resection, the bowel reattachment, was it good or bad? You know, and you might want to delay restarting therapy to day 3. So it's flexible at that point in time. And with low risk bleeding procedures, you basically start your therapy up the next day and patients are anticoagulated right away. So this is a simplified approach, certainly simpler than what we used to do with warfarin, and it's spelled out pretty clearly in the DOAC playbook. So I'm going to stop there and I'm going to turn it over, I think, to the next person. I'm not sure.
Thanks, Jack. So we're going to go into the next section there in the table there that we showed. There's a whole section on lab monitoring, and it describes when you might want to monitor what the DOAC activity is, that it may be beneficial. And it describes the different lab tests that are needed, that most institutions don't have this readily available, especially 24 hours a day, and what is needed to perform those tests. So we can go to the next slide. And we're going to talk about our case study. So this is RW. He's a 100-kilogram male that presented to the ER for severe abdominal pain. He'd been up most of the night and came in, and they did a CT, and it showed that he had a perforated bowel. So this surgery is needed, and you're asked to determine whether it may be safe to proceed. And so he's got a history of atrial fib. He's got hypertension, diverticulitis, and gout. His meds were apixaban 5 milligrams BID, Toprol XL 100 daily, lisinopril 20. And on the interview, he tells the provider he had taken his last dose of apixaban at 9 p.m. would be the one we would be most concerned with. His hemoglobin is 12 and his hematocrit is 36, and he has relatively normal creatinine of 1.3. So this table is in the book, and that shows us all of the available tests that can be run, as well as when you might need to do them. So if your institution was able to measure the activity for apixaban, you would need probably to be able to do a chromogenic anti-10A assay, and that's basically just going to tell you if there's drug on board. But if you know he's only taken it 5 hours ago, because it's 2 in the morning, and we've got that nice table in the front that shows the half-lives. The half-life of apixaban is 12 hours, so you know you're going to have drug on board. So this patient is probably not going to benefit from doing this. So you know that there's still drug on board. And then we could make the case for reversal if this person needs to go to surgery quickly. What are our options for that? The other thing you'd want to know is, is he hemodynamically stable? Can we support him? And what's the timeline for when they would want to take him to surgery if that was what's going on? If there is an urgent need to take him to surgery, then you would move down to the table for reversal agents. So I don't think we have to, this is just mainly to show you what is available for the different DOACs and what you could test. Dabigatran's probably the easiest because most places can do thrombin times for that. But with rivaroxaban and endoxaban, you can do a pro time, and that's just going to tell you if there's drug on board. It's not going to give you any quantification of how anticoagulated they are. So these are just mainly to tell you if there's drug on board. Any comments from anybody else that Arthur or Sarah, any other things on the lab monitoring? Because that's not my specialty for. Jackie?
I would comment briefly just to say that, we tend to do a lot of these assays, whether just a simple APTT or prothrombin time and so forth, and they're just not reliable enough to make a decision on. I mean, they may be, the PTT with the dabigatran may be elevated, it may not be when it's not, and the same with the PT with the rivaroxaban. If it's normal, it doesn't exclude significant amount of drug on board because the PT and the PTT respond differently based on the reagents and the instrumentation. And so you just can't be rely on that. And these other more complex assays, like the chromogenic assays, are either generally not available in many, many hospitals. And when they are, they're not available 24 hours a day, or they're not necessarily calibrated correctly for the DOACs and so forth. So it is a difficult situation, and a lot of the decisions are basically made on practical, judgment, if you will.
Yeah, I was just going to say kind of the same thing. You can't really rely on some of these tests, and the ones that you can rely on are often not available. I would point, folks who really want to dig into this, I would point you to any of a couple of Adam Suker presentations that he's done in the last, I don't know, 6 or 8 months, where he really digs into this very, very well. If you can find those on webinars or save somewhere, those are excellent presentations about this very topic.
Okay. All right. Thank you so much. So the next section in the playbook has to do with the PK/PD data. It gives you a table of the different drugs that can potentially interact, and the list also of drugs that you may need to adjust their dosages on the DOACs. There's some DOACs that would need to be reduced, such as apixaban for certain drugs. So we're not going to spend a lot of time on this. There's a very succinct table in the playbook for that. So now this next case study is going to go to Sara.
Hello. Okay, so this drug interaction case is a 38-year-old female who presents to the ER with acute onset chest pain and shortness of breath. She has a remote history of deep vein thrombosis that was provoked after surgery 10 years ago and was treated for 6 months with warfarin. She also has significant history of HIV and hypertension. Medications, you can see here, her antiretroviral regimen includes abacavir, lamivudine, darunavir, ritonavir, and then she's also on amlodipine for hypertension. Laboratory values, you can see they're essentially normal, except for a big, huge D-dimer, which we would expect given the following line where we see that she has a positive bilateral scan for a bilateral PE. And so if we look at this patient, first of all, with drug interactions, first of all, I think for me, HIV sort of automatically as a red flag for me, knowing that there's a lot of drug interactions with many of those drugs. And so that is a red flag. And then any drugs that end in VIR, VIR, are an automatic red flag for me, knowing I got to go look this up just to make sure. And so if we look at the next slide, we'll see the guidance tables here. So if we go back to one of those very first tables that we showed on patients or who should avoid DOACs, one of the recommendations that's highlighted there in yellow is we should avoid DOACs in patients who are taking medications known to significantly interact with DOACs. And I know this is somewhat vague because significantly can sometimes be in the eye of the beholder. So what we've tried to do within this guidance document is to look at the literature, look very clearly on what drugs are shown to be inhibitors or inducers of P-glycoprotein or CYP3A4 in humans with reliable published guidance or published data. And so the chart on the right is just a snapshot of the drug interaction guidance that we have for apixaban and rivaroxaban. And the first section is for inducers. And then the bottom of the chart is for inhibitors. And so you may remember that for apixaban and rivaroxaban, they are both substrates of PGP and CYP3A4. So the drug interactions, again, that are going to be most clinically significant are going to be drugs that impact both of those pathways. And so I will say for me, the combined strong inducers, this is super clear, black and white, very easy call. We avoid these drugs in our patients that would potentially be eligible for a DOAC. Then what we thought is, and there's manufacturer labeled guidance to support that. And then what we thought we should provide guidance on is something that's a little more unclear and less data driven, which is what to do with the strong CYP3A4 inducers where there is no PGP effect. And so we've given some examples of those here and just, stated there's limited data. We don't exactly know, the clinical significance of these, but it's gray. And so you have some room to sort of make a risk benefit shared decision making discussion there with the patient, considering their thrombotic risk, because with these induction reactions, you can see potentially a decrease in the DOAC serum concentration and thus an increased risk of thrombosis. So in a patient like we have here who has a brand new PE, I believe the risk of thrombosis would be high. And so I would be potentially concerned about using one of these drugs. Now, if we look at our patient in the inhibitor section, she's taking, or one of the components of her antiretroviral regimen is ritonavir. And that is one of the listed combined PGP and strong CYP3A4 inhibitors. And so we have some guidance on what to do with that with apixaban. So manufacturer labeled guidance includes if they're taking either the 5 or the 10 milligram BID dose, then the guidance suggests that we reduce that dose by 50% if they're taking one of these combined strong inhibitors, like ritonavir in our patient. And then if they were already on the 2.5 twice daily dose, let's say dose reduced for atrial fibrillation, or if they were on the long-term VTE prevention dose, then you don't have the ability to dose reduce that by 50%. And so that would be an avoid use type of situation. Then for rivaroxaban, we don't have that similar dose adjustment guidance. And so the recommendation here from the manufacturer is to avoid use of rivaroxaban in this scenario. So if this were a patient where, we really thought a DOAC was the most feasible choice, then apixaban is an option here, dose reduced for the ritonavir. And then the last column or the last row there is for combined PGP and moderate CYP3A4 inhibitors. And I think this probably gives us the most heartburn because we don't know what to do. And so these are drugs like that we commonly see, like dronedarone and verapamil, that are labeled as moderate CYP3A4 inhibitors. And there's no specific dose reduction or dosing guidance for apixaban. And then there's this sort of vague general statement on rivaroxaban about, look at, risk benefit ratio and avoid, if that is not in favor of benefit. If patients have, any level of moderate renal impairment. Practically speaking, I think we have to, keep in the back of our minds the amount of hepatic involvement of these drugs, which is not 100%. And keeping in mind that, and again, the practicality and feasibility, what's the best choice for the patient, and if it's a gray scenario, talking through that with them. And seeing, how much risk or concern there is. And then what I would also say is these don't exist in a vacuum most of the time. And so if we are looking at other factors that make us concerned, like older age or other drug interactions that are in play, if you have a combination of these two, if you have renal impairment, concomitant antiplatelet or NSAID therapy that you can't discontinue. Those are all things that I think about, in the big picture. And I try my very best to keep that patient on a DOAC, and then, have that discussion with them. And if it's just something that neither myself nor the patient feel comfortable with, then we go another route. But we just wanted to give you this guidance, and I will conclude with saying this is not all inclusive or exhaustive by any means. These are examples, and this is a highly dynamic field, and it changes pretty much daily. And so I would caution about relying on this list exclusively, as it's likely that a lot has changed, since we put this together. So use this as a guide, but also continue to update your searches as well, just to get the most up-to-date information.
Thanks, Sarah. So we're going to move into the next section in the book, which is the management of DOAC-associated bleeding. And I think some of the key things that are pointed out is the importance of supporting your patient during a bleed, because these drugs have very short half-lives. So can you just support them hemodynamically until they are no longer anticoagulated? And have you found the source of what's causing the bleeding? If it's a GI bleed, is somebody going in and putting a plug in the hole? And then how to determine, when do you need to reverse? What's a severe bleed? Do you need to get a drug level on this person if you can? What the reversal agents are, how to dose them and administer them, and what comorbidities could contribute to your decision to reverse or not. And then when do you resume the DOAC after bleeding? So our next case study is CN is a 73-year-old female, 73 kilograms, that presented to the ER after a ground level fall in which she hit her head and is complaining of a severe headache and weakness on her left side. She had a pulmonary embolism 12 months ago, which was unprovoked. So she's high risk there. Some hyperlipidemia. She's got CAD and had an MI 5 years ago. She's currently on dabigatran, 150 milligrams BID, atorvastatin 40 milligrams daily, toprol, and aspirin. Hemoglobin's 13, hematocrit's 20, creatinine's 1.2, and she had a CT of the head that was ordered. So this is what her CT of the head shows, and you can see there on the left side of your screen, she's got a bleed, which is probably giving her that really bad headache and the weakness. So we can go to our chart now, and if you remember, she's on the dabigatran, and is this a person that we would consider a life-threatening bleed? Well, I would certainly say so. Brain is very critical to survival, and she's already showing a significant bleed. So we would look to some guidance and see if we have the idarucicabide on formulary there. And you can see at the top here, we're going to go ahead and administer 5 grams of the drug. It's 2 separate vials, each 2.5 grams of the 50 milliliter vials. It is not recommended to take and try and reverse this with FFP. You could consider this if they're thrombin. You could consider hemodialysis if you don't have the reversal agent on board, or PCCs are usually available in all ERs, but you would definitely consider this a life-threatening bleed and would want to reverse it. You'd also want to ask if, I'm assuming that when this patient came in, she couldn't tell them when she took her last meds, because she sounded like she was pretty debilitated and going downhill. The other thing you want to worry about, though, is she's also had an unprovoked clot. So you want to make sure that we don't keep her off of her anticoagulation longer. So that's where it gets dicey, where you get the neurologist or the neurosurgeon on board if they're going to go in and try and evacuate after she's reversed, and figure out when it's safe to resume some sort of prophylactic dose and what dose to do. So I'm going to ask for some comments from the rest of the panel to see what else they think we should do with this patient.
I think that, well, what you said is correct in terms of reversal in this patient. The real issue for me, and I think for many people, as you were indicating, is when to restart anticoagulation in somebody who has a risk of ongoing stroke risk or thrombosis risk of some sort. And it's really not settled. It depends a lot on the bleed, how big, where is it? If we're talking about CNS, from subdural to intracranial, intracerebral. But I guess if I had to say in general, the studies, suggesting that somewhere between 2 and 4 weeks after the bleed, again, that's quite dependent on how the patient is doing and other factors, but somewhere between 2 to 4 weeks afterwards is to restart anticoagulation if it's still indicated.
Yeah, the biggest question is when to restart, and this is often what gets missed by the providers actually treating the bleed. And there is definitely a balance, but it's very clear that if you don't restart the anticoagulation in a close period, you have more thrombotic events that can be worse than the bleed itself. In a head bleed, it gets tricky, but definitely at least having part of your plan being to reevaluate that question and have the appropriate providers make that call is, I think, one of the most important things we can do.
I think one of the hardest things that I've seen with the reversals is when you have these patients that come in with the big bleeds in the head and they want to reverse them when they're, what's the likelihood of them being viable? I work at a big trauma center, and when they come in with the bleeds and they're non-responsive, you know, when do you pull the trigger to reverse or not reverse? And I don't think this is not a guide that's going to help you make that decision, but those are some of the difficult decisions we have with the DOAC use.
Yeah, for sure. These are some of this is driven very by emotion, right? I mean, you got somebody, it's like you want to try to throw the kitchen sink at to do everything you can. There were in some of their reversal trials, there were exclusion criteria specifically for head bleeds regarding the volume of the bleed in which patients were excluded. And so some facilities seem to draw hard lines at those points because this is how the study was done. Of course, you understand the reason the study was done that way was for the reason that you point out, that we have to make sure that we have somebody who's viable. So these are very tough, very emotional decisions, and it's my opinion really hard to draw hard lines in the sand on.
Okay. I think that was the last of our case studies, but we're just going to go through what's the remainder of the playbook so that we can open it up for questions. So make sure you're putting your questions in the Q&A. So one of the last sections is the management of the transitions of patients between hospital to home, a hospital to a SNF, hospital ward to the OR, and then the use of a discharge checklist for patients that are on DOACs will definitely help make sure that your patients have a smooth transition. There's lots of information about patient education, all of the Joint Commission safety goals surrounding anticoagulation are included in the DOAC playbook. So this will help you when you go to administration to show them why it's important that you incorporate these DOAC patients into your anticoagulation service because it's not okay to just prescribe and leave them go out the door without a touch point for their education as well as peri-procedural times and bleeding. Our resource center lists the decision making tools for shared decision making, the management of the DOACs, drug information, systems of care regarding like electronic records, order sets, disease management, side effect management, and medication management. So now we're going to turn and go to the question and answer. So I think Sarah's going to go first.
Actually, Arthur is going to address all the
okay.
questions about obesity because there's a ton.
Yeah, so as soon as I finished presenting, we got slammed with, but really, how big is too big, or how obese is too obese for DOACs? And a lot of these are coming from my VA colleagues. Probably know that I've gained a few pounds during COVID. That's probably where this is coming from. But we have some, we have the issue of obesity, as I mentioned it. My stance is still the same, that we don't necessarily know that anything is better in those settings. There are certainly pharmacokinetic concerns, which kind of drove the initial guidance from ISTH about the issues of obesity. And as I mentioned, a lot of that has been put to bed, but there are still these kind of cut points. Well, we're comfortable up to 120. We have data up to 110 kilos. So the questions that we're getting are really about the super obese patients, the patients with 150 kilo, 200 kilo patients. One of the things, I'm going to kick this over to somebody smarter than me, but one of the issues that I consider is you have to consider the case, right? So if I have a AFib patient with a CHA2DS2-VASc 2 versus a patient in front of me who has a saddle PE, brand spanking new saddle PE, those are two different cases with two different levels of concern about potential drug underexposure. And so, again, not a big fan of drawing lines in the sand. I don't think that it's a contraindication at any weight level. I think it's a matter of concern, and generally my approach is shared decision-making with the patients. But I want to kick this over to Jack Ansell and get his thoughts on this topic and see how much he disagrees with me.
No, I agree with you, but I think the thing that's interesting is, as you said, when you discussed the case that 4 or 5 years ago now, there was a recommendation not to use these or to avoid DOACs in obese patients. But there, I see paper after paper now, and I have a lot of them on my desk that look at either observationally and actually some prospective studies of obese patients and large patients, 200 kilogram type patients, and showing, at least one that I recall with rivaroxaban, that the drug levels were adequate, the outcomes were the same as in less obese patients. So the message that's coming through, I think, is that these drugs do not have to be dose adjusted in obese patients. Again, you may get a 500 or I don't know 600 pounder patient or something like that. I can't speak to that, but you know the sort of typical obese patients that you see that could be 200-300 pounds. I think that that you can go with routine dosing and feel comfortable with that. I'm not sure what the actual, I have to go back and see what the actual formal guideline is or recommendation, but the literature is coming through, just as it is on some other things that we've discussed today, where it's changing rapidly.
So I'd like to pitch another question to the panel. We've had several questions in the Q&A about is using DOAC for TAVR, because that was in our sort of suggested do not use lists. So Arthur, do you want to tackle that one first?
Yeah, that's great. And so the recommendation really would come from the Galileo trial, which was a negative trial, but it's so important when you talk about any of this valve stuff, really to ask about, is it contraindicated to use it in a patient with a TAVR, or is it contraindicated to use it as the antithrombotic regimen for the TAVR? If you look at those recent updates to some valve guidelines, I mean, for TAVR, patients are often just getting antiplatelet therapy as the antithrombotic regimen. There was a negative trial, yes, with low dose rivaroxaban in patients with TAVR. But since if I have a patient with atrial fibrillation, they're receiving therapeutic anticoagulation or therapeutic DOAC levels for that, and then they go in and have a TAVR, there's nothing to suggest that we now have to change them to a different drug, because again, we're anticoagulating the AFib. So whatever appropriate antithrombotic regimen is used for the TAVR will be used, but it goes back to for the TAVR or in a patient with TAVR, and the same is true for bioprosthetic valves or a lot of these other issues.
Yeah, I would add or just let everyone know there's a very nice summary of recent data that just came out literally this past couple of weeks from the European Heart Rhythm Association, which is a large document of about 60 pages or so, looking at anticoagulation with the DOACs in patients with atrial fibrillation. And it updates, it really includes literature that's come out just in the last year or so. So things have changed. And just as I think Arthur was pointing out in his case study about tissue valves, where the recommendations are changing now in terms of using DOACs. And even with TAVR, it's at least based on the recommendations of these cardiologists and group, is that based on at least one RCT that was done, but some observational data, and that DOACs are acceptable. Although, you know, a lot of these things need more studies and they change as the months go by. And I think one of the nice things about the DOAC playbook is that we can update this as new studies come out. It's not going to stay the same. And in fact, it's from the time that we finished the DOAC playbook, which was sort of 6 to 8 months ago, I think we've changed some things already in the playbook as it's been posted online. And we need to go back and update things just in the last month or two.
I'll go ahead and ask the next question. There's a couple of questions about antiphospholipid antibody syndrome and the use of DOACs in those patients. Sara, you want to take a stab at that?
Sure. I feel like the data that we have currently suggests that the triple positive antiphospholipid patients are the highest risk patients for thrombosis in general. And then in particular, seem to be higher risk for thrombotic events in especially those who take DOACs. And so for me, that is a clear steer toward warfarin. I think what is unclear is if they are, and I would say especially it's clear if it's arterial thrombosis. What is unclear is if they have APS with certain types of venous events, or if they're single or dual positive. I think that's less clear for me. Personally, I have, after the TRAPS trial data came out, I have left some antiphospholipid patients who had venous events that had done well on their DOAC. I have left them on their DOAC with sort of, more vigilance or what have you. But, that's sort of my approach to that. And I'd love to hear Arthur's and Jack's as well.
Yeah, I mean, so this issue, and actually, as I look at the Q&A questions, or other questions about other thrombophilias as well, should we be using DOACs and thrombophilias? There's nothing outside of, again, it goes back to should we not do it because we don't know we should, or should we do it because we don't know we shouldn't, right? And so with many of the thrombophilias, there's no reason to believe that we can't use a DOAC for those drugs. They didn't include thrombophilia testing as part of the pivotal trials, nor should they have. APS has emerged as this concern, specifically triple positive, but there's a few things with that. So as Sara mentioned, arterial events, even if if you look at the patients who failed in these trials, they often failed with an arterial event, which is super scary. Oh, sorry. Which is super scary. And so the issue really is, should we avoid DOACs in all APS patients? I apologize, guys. I got a phone ringing I can't control. Should we avoid, DOACs in all patients with APS? Generally, when I start with there's a diagnosis of APS, my first assumption is no, there's not. It's probably not accurate, and I have to go prove to myself to even have APS, much less triple positivity. So, curious about Jack as a hematologist about his opinion as well.
Yeah, I think the last comment you made is, for me, the most important, because I can't tell you how many patients I see that come with a diagnosis of APS, and they've had one test positive when they were sick in the hospital. And the criteria for having a positive APS is you have to have two tests. You have to have positive tests so many weeks apart, because you get transient antiphospholipid antibodies with various illnesses. So there are people that have this diagnosis that are really not APS patients. So you have to consider that, and to reevaluate them at the time, or just at least take it into consideration. I agree with you about arterial events. Seem to be the worst, and those are the most thrombotic patients. Triple positive versus single or double positive, meaning the different assays that are used. So it's not an all or none, I think. I agree with what Sara was saying. Certainly the triple positive ones, you want to go back to warfarin, but in the lesser cases, at least in my mind, it's not necessarily bad to avoid to include DOACs, but you have to look at it on an individual basis.
So Jack, I'd like to toss a question to you that we've gotten a couple of times in the chat about peri-procedural. Previously, one of the approaches was to base the pre-procedural guidance on renal function for all of the DOACs. And that's really kind of shifted, in the recent, I guess, months. So what are your thoughts on that? Give us your take.
Well, it still is, the Bigatran management is based on renal function, certainly because of the degree that the Bigatran is excreted by the kidneys. I think when you're talking about the other DOACs, rivaroxaban and apixaban, I think it's 33% and 25% elimination by the kidneys. Generally, it's not going to be a problem. Now, having said that, if a patient is having a procedure and they're quite ill, and something is going on with that patient, and you think things are changing, you need to, evaluate their renal function, their liver function. Actually, talking about liver function, that's another one of the questions came in earlier about liver function. And so, the liver function is relatively unimportant with the DOACs unless they have advanced liver disease, and that's a Child's Pugh B or C class liver disease, which is pretty significant. And otherwise, the DOACs are fine to use. So with liver disease, if a patient's on a DOAC, they haven't had liver disease, and then all of a sudden, and you don't monitor, you don't check the liver function at all, but all of a sudden they come in with jaundice, or they come in with ascites, or what have you, obviously you're going to check liver function and follow that and act accordingly. So the same thing with renal function. If the patient's coming in for a colonoscopy or for some procedure, everything else is relatively the same, I don't think it's necessary to check renal function for the 10A inhibitors, but with the bigatran, yes.
I think we have time for one more question. Arthur, you want to do one more or not? You're muted.
Amateur move. Apologies. Actually, I was just answering some on the Q&A, so if someone else has one in mind they want to pitch, that might be better. Let me get caught up here.
Okay, so I think the last one that we'll go with is probably the use of PCC for reversal versus andexanet if you don't have it, and what your thoughts are on that. Because I think most institutions have PCC on board, but a lot have not adopted. So what has your experience been in the inpatient setting with the use of PCCs?
I'll go first if I can, just briefly. Very few hospitals generally have andexanet alpha on board or at the hospital. The large academic medical centers maybe have it, but PCCs are available at almost most hospitals, perhaps except for the very smallest. And so if you were to do a survey today, I think the overwhelming use for reversal, if the reversal is used, it's probably going to be PCCs and much less andexanet alpha, mainly because of the cost associated with andexanet alpha and its availability. So, PCCs, there's evidence, they're not randomized trials or head-to-head trials, but there's a reasonable evidence that it does have a reversal activity or reversal efficacy with the DOACs. And the downside with PCCs is that it is a prothrombotic agent. You have to be very careful about that. So I think all I need to comment.
Okay, well, thank you to all of our authors, Arthur Allen, Jack Ansell, Sara Vazquez, and Diane Wirth. Thank you so much for walking through this important new resource from the AC Forum. And I hope everyone in the webinar will find this DOAC playbook useful. I also want to acknowledge Nate Clark, who was a great contributor to this playbook. We had over 750 people on this webinar, and I think close to 80 questions, which shows definitely the need for this guidance. I love Diane's analogy of a cookbook, and I hope this gives you the ingredients you need to confidently manage DOACs. You can find this DOAC playbook in our centers of excellence, along with all of the detailed resources that expand on each topic. As usual, this webinar has been recorded and will be posted on the AC Forum website next week, so you can share it with colleagues. Also, the webinar is accredited for live and enduring credit. And you can find the link to claim credit on our website, acforum.org. Our next webinar is Tuesday, May 25th. You can see the topic here, effectiveness and safety of DOACs versus warfarin in patients with valvular AFib. Arthur spoke briefly about this today, but we'll dive deeper at the end of the month. And I'm very pleased to announce that we are moving forward with a live in-person meeting in October in San Francisco. So if you found the topics discussed today useful, we'll go much more in depth over 3 days at the conference. And we have over 35 speakers that will be in person. So a great opportunity. And lastly, I'd like to thank our sponsors for supporting this webinar program. Thank you so much for joining us and have a great day. Thank you.